So with that, I am going to introduce Dr. Marina Rabin. Thank you so much for being here with us tonight. We're really excited to listen to your talk. And so just a quick bio on Dr. Rabin for those of you who aren't familiar. So Dr. Rabin, she originally comes from Russia as a refugee. She came in 1988, and she completed her medical training at Boston University Medical School, and then at Beth Israel Hospital, Harvard Medical School for her OB-GYN residency, followed by a postgraduate board certification in female pelvic medicine and reconstructive surgery, so urogynecology. And as a part of her devotion to women's health, Dr. Rabin has also completed board certifications in obesity medicine and in lifestyle medicine, as well as a fellowship in restorative medicine. She currently practices at the Women's Health Division at Community Health Center of Cape Cod, and she has 4 children and a dog and currently lives with her husband on Cape Cod in the US. So yeah, thank you so much, Dr. Rabin. We're really excited to hear what you have to say, and with that, I'll pass it on to you.
So thank you very much for the introduction, and thank you for inviting me and allowing me to share my patients' stories.
Of course.
Here we go. So, okay. And the slide is not moving. Oh, here we go. Sorry. Disclosures. Although I devoted my whole life to the women's health, and I am many things. I'm an OBGYN, I'm an menopausal specialist, urogyn, I'm integrative medicine, obesity and lifestyle medicine physician, but I am definitely not a hematologist. So this presentation is based on my clinical experiences only, and it is not meant to supersede any standards of care. And as with any new information, please use your clinical judgment and use the protocols when clinically relevant. I am sorry for the slides. I'm receiving honorarium for this talk from you guys. Objective here would be to discuss treatment of iron deficiency anemia with a modern twist. Iron deficiency anemia is a disease as old as times. It is a common public health problem in the United States and in Canada, and I'm sure in Australia as well. According to National Institute of Health, 1 in 3 Americans have undiagnosed iron deficiency, and 1 in 4 Americans have an inadequate iron intake. Of course, first people to suffer is us women. So about 1/3 of us in non-pregnant situation have iron deficiency. And if we go into pregnancy, 40% of women have iron deficiency anemia, and 42% of children, as rapidly growing people, also have iron deficiency. Please meet my 2 very favorite patients. On the left is Miss Pauline Pale with heavy periods, and on the right is Mrs. Defined Deficient, a vegan with Crohn's disease. So Miss Pauline Pale is a 30-year-old G0 patient with regular heavy periods. Pauline complains of unexplained fatigue, lightheadedness, palpitations, frequent headaches with activity, and dry skin. Her hematocrit is 29. She has microcytic anemia. Her iron and ferritin are decreased, and her transferrin is increased. Her vitamin B levels are normal. And as we all know, anemia is a condition when the body lacks enough healthy red blood cells to carry adequate oxygen to tissues, leading to fatigue, weakness, and other symptoms. And one of the most common causes of anemia is deficiency of iron or B vitamins, which are vital for the production of red blood cells. And if you look at the red blood cells here in anemia, they are smaller, they are hyperchromic, and there is less of them. And they are called, these are called target cells. These ones, abnormal shaped, are called teardrop cells. And of course, those are reticulocytes. Symptoms of iron deficiency, like Pauline Pale has fatigue, shortness of breath, tachycardia, hair loss, brittle nails. increased sensitivity to cold. I'm sitting in this warm blanket. And of course, brain fog, which seems to be a common denominator to all of our problems, but definitely to iron deficiency. So health benefits of iron are multiple. First of all, it's brain function and muscle function. Definitely, iron is very important for good sleep quality and length of sleep, immunity, and temperature regulation. Okay. Anemia is not the beginning of, but the end stage of iron deficiency, not an early marker of it. Iron deficiency starts with, like we can see here on the table, iron deficiency starts with decrease in ferritin on the blood test. Then there is increase in total iron binding capacity and decrease in iron saturation. And then there is decrease in MCV, and only at the very final stage, there is decrease in hemoglobin. So when somebody comes in with, let's say, hematocrit of 36 or hemoglobin of 12, however, their iron saturation is low or their ferritin is low, those people do have iron deficiency already. They're just not anemic yet, but they still need to be treated, or the cause of their iron deficiency should be investigated. Dietary iron comes from the heme and non-heme sources. However, in our body, obviously more than 95%, so almost all functional iron is in the form of heme. Heme iron, which is present mainly in meat, poultry, and fish, is very well absorbed at a rate of 15 to 35%. However, non-heme iron, which comes from plants, is much less absorbed, and the rate is cited as, depending on the studies, at 2 to 20%, and generally on average is about 5-7% of non-heme iron absorption. Additionally, non-heme iron is usually bound to phytates and tannins in plants, and therefore requires vitamin C, vitamin A, beta carotene to help it get absorbed, which is also another difficulty for it. Then iron travels. Iron gets into our body with food, either meats, poultry, and fish, or lentils, dark lean leafy vegetables, tofu and tempeh, iron-fortified cereals, and it gets into the stomach after it is dissolved. In the stomach, stomach converts ferric or iron 3+ insoluble iron to ferrous iron 2+ soluble, which is easily absorbed in duodenum and the proximal jejunum. Causes of iron deficiency. I'll go quickly over them because most of us obviously know that. Most frequent cause of iron deficiency is blood loss, like heavy periods, fibroids, childbirth, and some sort of internal bleeding, usually GI. Another frequent cause is poor diet, like low iron intake, and we just talked about iron-rich foods. Another cause is inability to absorb enough iron from food. Like people with duodenal disease, like celiac disease or inflammatory bowel disease, are not able to absorb iron well. Inflammation usually activates local hepcidin. Hepcidin is a peptide produced by the liver during inflammation, and it suppresses the protein ferroportin, which is the protein that helps iron get transported from the intestinal cells into blood. So inflammation in the bowel prevents iron absorption. In antacids, as we know, this decreased stomach conversion of iron 3 plus to iron 2 plus, so iron remains insoluble and doesn't get absorbed. And vegan diet, from vegan diet, although vegan diet might contain a lot of iron, but only 7 to 9% of it is absorbed. So vegans frequently have iron deficiency in addition to the B12 deficiency that is well known. People at risk for iron deficiency, like we just talked about it, rapidly growing people, infants, children, and adolescents, people not getting enough iron with diet, like seniors, vegans, pregnant or breastfeeding patients, and patients with inflammatory bowel disease. Women with heavy periods, and people on long-term ibuprofen or aspirin. Estimated daily iron requirements are different by age and by gender. Men usually require less iron than women for obvious reasons, because they don't have periods and they never become pregnant and don't breastfeed. And older people usually need more iron than younger people, also because of the decrease in absorption. So Miss Pauline Pale, our 30-year-old with regular heavy periods, complains of all the symptoms of iron deficiency and has a hematocrit of 29. Obvious treatment would be birth control pills. However, Pauline declines birth control pills or Marina IUD or any other hormonal contraceptive treatment, as she wants to get pregnant in a year or so. So in America, the simplest, the easiest, and the cheapest way to treat iron deficiency is iron sulfate. So here we go. Iron sulfate, 325 milligram tablet, contains 65 milligrams of elemental iron. And if we give it 3 times a day, then there is 195 milligrams of daily elemental iron, which results in about 10 milligrams of iron absorbed. It costs around $5 per month, so very cheap. However, this 195 milligrams of elemental iron with only 10 milligrams of iron absorbed leaves a huge amount, 185 milligrams of unabsorbed iron, that causes gastroparesis, or slowing of the gastric emptying, and that leads to nausea, epigastric discomfort, constipation, and sometimes just GI discomfort with diarrhea. So Pauline quickly develops nausea and constipation on iron sulfate, and she was able to tolerate it only once daily. A month later, she comes in and tells me that she was taking iron sulfate only once a day, and her hematocrit didn't change. It's still 29. So then I decided to switch her to iron gluconate and emphasize the importance of taking it 3 times a day as prescribed. Of common iron supplements, iron gluconate is also 325 milligram tablet, but has 36 milligrams of elemental iron. It's also taken 3 times a day. There is also iron fumarate. Cost is much more, they are much more expensive, both of them. Iron gluconate is $8 per month, but iron fumarate is about $45 per month. They have less elemental iron than iron sulfate, but are much better absorbed and cause less side effects in those sensitive to iron sulfate. However, they, like all common iron supplements, they should be taken on an empty stomach 1 hour before, 2 hours after meals. They're a little bit better tolerated. After 2 months of taking iron gluconate 3 times a day and tolerating it reasonably well with just mild nausea, Pauline's hematocrit is only 31, and she's still symptomatic. She says that her palpitations are gone, but headaches, fatigue, and dry skin are unchanged. So at this point, I'm starting to think about less common and more advanced iron supplements like iron protein plus, thiazole, iron bisglycinate, Ferromax, or flow iron. Thiazole combines heme and non-heme iron, which allows for better absorption and minimal GI side effects. It can be taken with or without meals, and it is a once-a-day preparation. Heme iron supplements like porphyrin are made of hemoglobin extracted out of cow's red blood cells and are very expensive, $50 to $150 a month. They are much better tolerated than iron salts and are easily absorbed if there is no intestinal inflammation. And of course, IV iron is ferric oxide and iron dextran, iron sucrose, or iron gluconate preparation. Generally, IV iron, as we all know, is much more effective. It delivers 50 milligrams of elemental iron per 1 milliliter of solution. It is extremely expensive. It costs about $500 per month, and it has sometimes very significant side effects of lightheadedness, urticaria, fever, bronchospasm, arthralgias, and various hypersensitivity reactions. So now we come to talk about the new kid on the block, which is Ferrosome Forte. Ferrosome Forte, the hero of our talk today is liposomal iron preparation. It's once-a-day preparation that can be taken at any time of the day and does not need to be taken on an empty stomach. It has excellent absorption and delivery and has no GI side effects. And the cost of it is about $40 American a month. So I'm going to talk a little bit about liposomal drug delivery because it's just so cool, and it is a modern solution to increase efficacy and decrease toxicity of different medications. So liposomes are simple water vesicles surrounded by phospholipid bilayer membrane. Liposomal drug delivery is new and a very effective therapeutic platform. Liposomes greatly improve medication and nutrient delivery to specific body targets. So that's a medication that needs to be delivered, or some sort of a nutrient, like let's say vitamin C in this picture. And it is surrounded by phospholipid bilayer. Liposomes decrease drug efficacy and decrease toxicity. So on one hand, because of the phospholipid bilayers, they protect drugs from destruction. And on the other hand, they protect us from any drug side effects until the drug is delivered to its target place. And liposomes deliver drug in the desired form to a desired place in the body and enhance intracellular drug uptake. Liposomes can incorporate both water-soluble, like in here, for the hydrophilic or water-soluble load, or lipid-soluble medications, which is hydrophobic load, which is stored in the phospholipid bilayer. Drugs are delivered by endocytosis, fusion, or intermembrane transfer. Once they brought, like the liposome comes over here to our cell and just brings in the drug. The applications are multiple. It can be drug delivery or any medication delivery, vaccine delivery, gene delivery, or enzyme delivery. It could be radiodiagnostics, and it could be in various anti-aging therapies. The current major disadvantage is only one, and it is a higher cost. Going back to liposomal iron, liposomal technology protects iron element until it reaches the liver, ensuring maximum absorption and maximum effectiveness. And thanks to liposomal technology, iron supplement is gentle on the stomach and intestinal mucosa and will not cause pain, diarrhea, or constipation. So, as far as Ferrosome Forte, Ferrosome's liposomal iron has this LCE or lecithin emulsifier coat, which stabilizes, which is on the, so that's the iron, that's the phospholipid bilayer, and on the outside is this liposomal lecithin emulsifier coat that stabilizes liposomes and protects the iron from stomach acid. And the LCE code allows iron liposomes to be absorbed via endocytosis throughout the small intestine, not just in duodenum and the upper jejunum, but throughout the small intestine, and enhances iron absorption and delivery. This LCE code specifically makes ferrosome forte as effective as IV iron. There is no metallic taste, it's easy to swallow, and in addition to that, iron in this preparation is combined with vitamin C for enhanced iron absorption. I wanted to show you another cool thing. So conventional iron absorption goes through the intestinal cells and gets into the bloodstream. Our small intestine also has M cells that are usually used for specific antigen or antibody deliveries. And there, the absorption goes almost like passive absorption, and it goes into the lymphatic system. And the ferrosome iron, because of the LCE coating, can go through the M cells throughout the intestine and be absorbed into the lymphatic system and then go bravely and readily into the liver. So, Miss Pauline Pale. Since Pauline's hematocrit is only 31 and she's still symptomatic despite trying 2 iron preparations already, I have decided to switch her to ferrosome forte capsules, 1 capsule a day. She tolerates it well without any side effects, and 2 months later, she is completely asymptomatic. She feels well. Her weakness, lightheadedness, and skin dryness are gone, and her hematocrit is 36. Woohoo! So, Next patient. Mrs. Defined Deficient is a 73-year-old G3P3 vegan patient of mine with Crohn's disease. Mrs. Deficient comes in and she complains of increasing weakness, occasional dizziness, cold hands and feet, brittle nails and hair loss worsening over the last year. Defines TSH and free T3 are normal. Her hematocrit is 32. She has microcytic anemia. Her iron and ferritin are decreased, and her transferrin is increased. Her vitamin B12 level is also decreased. So, vegan diet is frequently deficient in iron and also frequently deficient in, and also vegans are frequently deficient in B12. 20, as I said before, once again, 20-30% of iron from meats, but only 2 to 20% of iron, or on average 7 to 9% of iron from plants are absorbed. Although lentils and dark green leafy vegetables have plenty of iron. Meats contain vitamin B12, which is frequently deficient in vegan diets and should be supplemented. So Mrs. Deficient, complaining of increased weakness and cold hands and dizziness, and who has, as we found out, vitamin B12 deficiency, and in addition to that, iron deficiency anemia. I started her on B12 supplementation, and I started her on thiazole biferra, which has both heme and non-heme iron and has excellent absorption. She complained, after starting thiazole biferra, she complained of increased abdominal cramps and increased diarrhea. And her hematocrit in 2 months only changed from 32 to 33. So, as I mentioned before, iron absorption and release are regulated by liver peptide hepcidin. And hepcidin, when there is increased inflammation, hepcidin is increased, and hepcidin blocks this guy that's called ferroportin, which helps iron get absorbed into the from intestinal cells into the blood. So low hepcidin is good, and high hepcidin is bad. And inflammatory bowel disease or inflammation in the bowels promotes liver synthesis of hepcidin and decreases iron absorption. So people with Crohn's disease or with inflammatory bowel disease in general have iron deficiency. And non-heme iron supplementation, especially in people with inflammatory bowel disease, can cause oxidative stress and direct inflammation of gastric and intestinal mucosa. Heme iron, which in thiazole biferro 50% of iron is heme iron, is more soluble and less likely to damage stomach or intestinal wall, and is absorbed differently. Heme iron is absorbed differently through different pathways than non-heme iron and is less affected by intestinal pH and diet. Liposomal iron is not affected by the pH or diet. Ferrosome, as we just discussed, ferrosome iron, which is coated with the LCE coating, is absorbed throughout the small intestine and can be absorbed by intestinal cells and M cells. So much less depends on inflammation or on hepcidin, or is not dependent on hepcidin or ferroportin. So in 3 months, I'm sorry. So since, sorry, Mrs. Defined deficient still complains of increased weakness, occasional dizziness, cold hands and feet, brittle nails. She has symptoms of increased intestinal inflammation. Because of that, we decided to move to Ferrosome Forte, 1 capsule a day for 3 months for her. In 3 months, she reports that her weakness, occasional dizziness and cold hands and feet, and brittle nails and hair loss all improved. Her hematocrit rose to 37, and then I switched her to daily ferrosome sachets, which is much lower dose for maintenance. Liposomal iron absorption is not affected by food intake or by hepcidin levels, as I said, and frequently increased, which is frequently increased in patients with inflammatory bowel disease. In conclusion, first of all, anemia is a condition where body lacks healthy red blood cells to carry enough oxygen to tissues. Heme iron from meat is absorbed much better than non-heme iron from plants. Vitamin C increases iron absorption, whereas grains, tannins, fiber, calcium, and phosphorus decrease it. Common iron supplements such as sulfate, gluconate, fumarate are taken 3 times a day on an empty stomach. Sulfate is most effective but causes gastroparesis and GI side effects. So although most effective, it causes most side effects as well. If we're talking about more advanced iron supplements, such as thiazole biferro, slow iron, or iron bisglycinates, they are taken once a day and they are much better tolerated, but they are not always effective. IV iron is very, very effective, but it has multiple side effects and inconveniences, and it is also very, very expensive. And our new kid on the block and hero of today's talk, called Ferrosome Forte, is a liposomal iron with LCE or lecithin coating for enhanced absorption and delivery. It has essentially no side effects except for a higher cost, and it is very effective, especially in cases of chronic blood loss or altered intestinal absorption, such as celiac disease, Crohn's disease, or bowel inflammation. Generally, it is more expensive than other iron supplements. Thank you so much. That's the end. Jyoti, I'm
Hi,
done.
Dr. Rabin. Thank you so
Your
much for the
schedule.
presentation. Yeah, no, you're great for time. And we have quite a few questions, and I sense a lot more are coming. So you ready to get into the Q&A?
Absolutely.
Okay, so let's see. Um, okay, one question here. So with all the information that you provided with all the different supplements, why is it that we're not starting with the liposomal iron to begin with?
Um, it's a very good question. And if just the only reason is the cost, the only reason is the cost. If it were not for the cost, I would probably start everybody on the liposomal iron right away. But especially now I work at the community health center, so not every patient has means to spend on over-the-counter products, and iron products are not covered by the insurance. Then in that case, iron sulfate is $5 a month, and ferrosome is around $40 a month. So for very simple cases, some people tolerate iron sulfate, not that, and can get better.
Okay,
So that's the only reason.
makes
Yeah.
sense. Uh, let's see here. Okay, is taking iron supplements every 2 days instead of an everyday basis more effective?
I would say that if somebody has iron deficiency anemia, you'd have to take iron sort of as prescribed. So if it is 3 times a day, it has to be taken 3 times a day. And if it is a preparation such as liposomal iron, it is a once a day preparation, thankfully. So that is once a day, but it's not once in 2 days or something. If somebody just is on maintenance, like my Pauline Pale after her hematocrit rose to 36, or Mrs. Defined Deficient, once her B12 and iron deficiency are corrected and her hematocrit is also normal, then you can either do ferrosome sachets, which are less expensive and which are lower dose liposomal iron once a day, or you can do some sort of other iron preparation for maintenance in any regimen that you want, that, for as long as the patient's hematocrit is stable.
Okay, awesome. So why is it sometimes that the iron result is low, but ferritin is high? Could you speak to that?
Then, so low iron with high ferritin. Um, so 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 ferritin can be elevated, with low iron. In general, ferritin is a marker of inflammation. Ferritin can be a marker of hemochromatosis, right? So high ferritin is not, but high ferritin with low iron, I think it could be anemia of chronic disease or anemia of chronic disease plus iron deficiency.
Okay. So next question, and you did explain this a little bit, but maybe like in a quick nutshell, um, could you explain how the liposomal iron form doesn't cause constipation?
Why it doesn't cause constipation?
Yes.
So constipation is usually caused by iron because iron absorption is low and there is a lot of iron that is left unabsorbed. And unabsorbed iron causes gastroparesis and intestinal slowing. And as I said, like if we take iron sulfate 3 times a day, we are getting out of it about 195 milligrams of elemental iron, of which 10 milligrams is absorbed, and we are left, or our stomachs and our intestines are left with 185 milligrams of iron a day that is unabsorbed and that just has to slowly but surely come out. And that iron causes constipation, gastroparesis, slowing, nausea, constipation, and all this stuff. Whereas with liposomal iron, it is 100% absorbed, so there is no iron left to float and to cause any side effects.
Awesome, thank you. Okay, once an iron supplement has been initiated, and and the labs return to normal, can the iron supplement be discontinued? Like, what's your process for maintenance?
It depends on the diagnosis. So if somebody had some sort of, let's say, acute blood loss, like childbirth, and is doing fine now, and or somebody had heavy periods and you started them on birth control pills and their periods lightened, or you put in Marina IUD and their periods lightened, and and you gave them some iron supplements and their hematocrit is normal, then it can be discontinued. But if somebody has an ongoing chronic blood loss, then that's a different story.
Okay.
So for my two patients, once again, Pauline pale and defined deficient, who are both chronic iron losers, they'll need some sort of iron supplementation.
Like a maintenance, ongoing maintenance, right?
Maintenance, right?
Okay. Well, we have a lot of questions. So,
That's good.
yeah, so how long after starting Ferrosome will you see an improvement in the hematocrit?
In both patients, I saw an improvement in 1 month, but I think a couple months probably for a full. I mean, once again, it depends on, how low hematocrit is to begin with. If somebody has, and it's sort of, yeah, reverse correlation. So if somebody has hematocrit of 25 in 1 month, you'll see a huge improvement. If somebody has hematocrit of 33, you probably need a couple months until you see a full improvement.
Okay, good. Yeah, that makes sense. Okay. Um, let's see here. Okay, it's an advice question. So, in a diabetic or a patient with diabetes who has heart failure, it's an elderly patient, normal hemoglobin, normal RBC count, low iron, normal B12. What's your advice?
So once again, elderly patient with diabetes. Can you repeat the
Yes.
question for me?
Yep, elderly patient with diabetes, heart failure.
Mhm.
Um, and so normal hemoglobin, normal red blood cell count, normal B12, but the iron is low. What's your advice for this for this patient? Like, what would you
So the
recommend to start
first
with?
question is, why is her iron low? That's a woman, I'm assuming. Why is her iron low? I mean, I would be concerned about, the GI bleed or some sort of, slow GI bleed or subtle occult GI bleed, and just investigate that in terms of, stool guaiacs, colonoscopy, or whichever way we investigate this whole thing. Provided that everything turns out negative, I would just supplement her iron to bring it up, because as we know, she does have iron deficiency. She does not have iron deficiency anemia. But if we do nothing, then it will just go through steps. So from low iron to low total iron binding capacity, and then finally to low hemoglobin.
Okay.
Yeah.
So, if absorption for ferrosome is great, does it matter if taken capsule versus powder version of ferrosome? Will the powder one work better? Like, I mean, we can always answer this question as well. If anybody has any product specific questions, we're going to hang on and answer them for you. But Dr. Rabin, I'm curious to know, like, which one do you recommend to your patients, the sachet or the capsule?
So depending on, once again, depending on the extent of anemia. So if somebody, for me personally, I do capsules for treatment and sachet for maintenance, because my sachets, they have much less iron in them.
Okay.
So the content is much less. I mean, absorption is excellent either way. It doesn't matter if it's capsule or if it is powder, but powder bags contain much less iron.
Yes.
They just designed that way.
Yeah,
So,
that makes sense. Capsules for treatment and then sachet for
mhm,
maintenance. Okay.
mhm.
And then there is another question. A couple questions came up regarding pediatrics. Obviously that's not in your realm of expertise,
Right.
but I
No.
just wanted to just quickly
Uh-huh.
answer. Yes, it can be used for pediatric patients. We have information on pediatric dosing if you ever want to like just reach out to us as a follow-up email to reply to our follow-up email. We can send you that information. But
I absolutely, if I absolutely would use it for my kids before I would start using any other iron. So potentially for people who are able to pay, just, kids are always complaining of abdominal pain, or diarrhea, or constipation, or nausea, or I don't want to eat this, I don't want to eat that, I don't feel like it. So if you use something, for the kids, it's just so much better to use some liposomal technology where there's definitely no side effects, and that it's, whatever they're complaining about is not the side effect of a medication.
That's such a good way to think about it. I've never, I've never heard it put that way, but it's like you're just eliminating a pain point,
Right.
right? Okay.
Yeah.
Making it easier for everybody. All right. So, okay, patient has normal hemoglobin but low ferritin. Should they be treated with an iron supplement?
Yes.
Okay.
So that's once again to the question of iron deficiency without iron deficiency anemia. So
Yes, we have
those
a
people
question.
should be, first of all, there should be some investigation unless it's obvious, like, young woman with heavy periods. But if it's an elderly person or a person who already does not have periods, then there should be some GI workup or some sort of a workup as to why they have low iron stores. But in terms of treatment, yes, because otherwise that will progress. Yeah.
Okay. So just to clarify then, um, iron deficiency
Is the
could be
first step is the first step. So iron deficiency anemia is the final step of iron deficiency.
right. And that's when your ferritin is low,
No,
everything's
ferritin, it starts with ferritin being low, actually. So
yes.
first thing is decrease in ferritin. Second step is increase in total iron binding capacity, total iron binding capacity, and decrease in iron saturation. Third step is decrease in MCV, or decrease in the volume of the red blood cells.
Got
And
it.
last step is decrease in hemoglobin.
Okay. So when that ferritin is showing low, treatment
That's
should
the first
should
step
be,
of
yeah,
iron deficiency, and then the treatment should be initiated. Right.
perfect.
Mhm.
Okay. So another question is
And
with
then you can use sachet. You don't have to
exactly,
use, yeah,
exactly.
or something mild. Yeah.
There's a question here I just wanted to quickly address. Would the liposomal iron be easier to absorb for patients post-bariatric surgery? I know you're not a bariatric surgeon, but you did
But
speak
I am obesity
exactly.
specialist.
Yes. So if you wanted to,
So
to speak to that quickly.
I actually, doesn't matter. Doesn't matter from no, same as for other people, because it's absorbed in duodenum and in upper jejunum. So iron gets absorbed. So either way, let me actually, my husband is an obesity physician. Let me ask him. He's walking around over here. What do you think? Is liposomal iron better absorbed in like post-bariatric surgery than in a regular person?
No, it should not affect
Should
much.
not
Yeah.
affect it. Yeah, he thinks the same way. Yeah.
Okay,
So
perfect.
we think it doesn't matter. That part, it doesn't matter.
Okay,
It would be better in general for everybody, but from the standpoint of bariatric surgery, we think it doesn't matter.
okay.
Yeah.
Um, oh yeah, we got a couple of bariatrics. Okay. Could you
Go
please
ahead.
comment on taking vitamin C 500 milligrams with iron sulfate to increase iron absorption?
Yes. So vitamin C definitely increases iron absorption, and so does beta carotene, and so does vitamin A. But vitamin C is so it's we always advise people who are taking conventional iron to use vitamin C. With liposomal iron, it's not necessary, but your preparation, I noticed, does have vitamin C.
Mhm.
I don't know
Exactly. Yes.
why. I don't
The
know
reason,
why. I think it's just for just in case. Why not?
yes,
Because it's
that's the
brought
reason.
directly
It's
into cells.
people are used to, seeing vitamin C with their iron. So
Right.
it's been included. And then it's
Right.
not necessary for liposomal iron, but it was included to help increase the iron absorption of just like their dietary iron intake as well. It
Mhm,
was just
mhm,
seen as
mhm,
like
mhm,
just an
mhm,
added bonus, but not a requirement.
mhm. So vitamin C has two functions. First of all, it helps, ferroportin, or the protein that transfers iron across the intestinal border into the blood. And secondly, it creates sort of more acidic environment where iron 2 plus would not convert back to insoluble iron 3 plus. Yeah.
Nice.
So yeah.
Okay, we have time for a few more questions. So, would liposomal iron be recommended in long-term PPI use in GERD or patients with reflux who had prior GI bleeds?
As opposed to conventional iron.
Yes.
So sort of once again, it's more of a stomach issue than GERD, and the long-term PPI use than the issue of intestines. So it would not be different. I mean, I think that in general, for people who need long-term iron, liposomal technology is wonderful because you don't want to be long-term constipated or have long-term nausea or any side effects that are mild, that are for someone who is on iron for 1 month is probably more tolerable than for someone who is on iron for long-term.
Mhm.
But so from that standpoint, yes, but from the standpoint of absorption or efficacy, I think it's the same for whether a person does or does not have GERD.
Okay.
Yeah.
Could you speak to the use of liposomal iron or ferrosum in pregnancy, during pregnancy?
I do not see why not, but I do not know if the studies have been done on liposomal technology in pregnancy.
So
Yes,
for
I think
ferrosum, it's been approved by
for
the
you,
SOGC here in Canada, the Society of Obstetrics and Gynecologists. They've approved it for use in pregnant women. But I guess in terms of the question for you, it's like, would you recommend, like, can you see this product or liposomal iron benefiting pregnant women composed to conventional iron?
I think that definitely for pregnant women who have anemia, because in pregnancy, elevated progesterone and pressure from growing uterus, cause a lot of constipation. So constipation is our common problem in pregnancy. So not adding iron that causes constipation and nausea is a common problem in pregnancy as well,
Yes.
and we all know. So liposomal iron would be a very welcome addition, in addition to the fact that it is more effective than conventional iron. So yes.
Awesome.
Especially if somebody needs iron, then yes, liposomal iron would be very good. Yeah.
So I'm
I'm
going to
not
do,
sure if FDA in America has approved it. That's the only thing.
I would have to double check. I would like to say yes,
Mhm.
but I can't verify without double checking.
Right.
Okay, I'm gonna do 2 more questions. So this next question is a bit of a little case study, and I think it's always great if someone's sharing something about their patient, if they could get an answer, why not? So I'll read this. Let me know if you're following. So if a patient has heart failure with high BNP levels, it's an elderly male patient. He's on
Mhm.
he's on cardiac medicine. He has low hematocrit and RBC levels, slightly high to normal ferritin, and low to normal iron. Would supplementing iron exacerbate the heart failure, or would its supplementation be warranted?
What do you think?
Will not exacerbate if he has no anemia. It will not exacerbate heart
So
failure.
how low is hematocrit?
Don't know.
If hematocrit is low,
If hematocrit is really low,
then improvement of hematocrit.
yes, then improvement that hematocrit is really low, let's say below 33, 32, below 33, 32, then improvement in hematocrit would improve the heart failure. If
Right.
hematocrit is around 34 or something, and he has normal ferritin or slightly elevated ferritin, and then I'm assuming that once again, part
20.
of his anemia is
They
anemia.
just, sorry to interrupt, they just responded. He said it's 20 and it's falling.
20. Oh,
Yeah.
that's really low.
Yeah.
That's really low.
Exactly.
So then he needs iron supplementation. Yeah.
Okay. So it wouldn't,
Yeah.
you would say it wouldn't, it's the heart failure
Do we
exacerbating.
think that his hematocrit, I mean, do we think that he has iron deficiency anemia? What about other, parameters except for the ferritin? Once again, I heard that his ferritin is normal to slightly elevated. That doesn't go with iron deficiency. So does he have, what's his iron? What's his total iron binding capacity? What's his iron saturation? Does he have iron deficiency is my question,
Interesting.
Oh,
that's a good point.
and
Okay.
or does he have anemia of chronic disease or something else entirely, or what's his, B12 level, folate level, whatnot,
Okay. Well, something to
So
think about, I guess.
Yeah.
Yeah.
Just,
Thank you.
but in general, if he does have iron deficiency, then at hematocrit of 20, yeah,
Very low.
he does need to bring it up because that would definitely help his CHF and he'll feel better overall. Yeah,
Okay, good.
yeah.
Okay, I'll do one more question.
And I'll look up the American situation with liposomal iron in pregnancy, and I'll send an email, and you can send
Thank
it
you.
to whoever was asking, to everybody. Yeah.
Appreciate that.
So another question.
Okay, so last question, let's see. There's so many. Okay, what if someone takes too much iron? Let's end it with that.
Too much iron?
Yes.
What to do about it?
Or like, should you be concerned of giving someone too much iron? Like,
Yes.
that's the question.
Too much
Like,
iron is not good. Too much iron is definitely
like
not.
what could happen if they're taking too much iron? Like, what are the things to look out for?
Well, people can have liver toxicity. People can have hemosiderosis. Yeah. Hemosiderosis, iron deposits in the liver, iron toxicity. Yes.
And would
So
you say
much
that,
iron. Yeah.
would you say that signs of them taking too much iron would be they're getting a lot of this GI side effects, but their blood levels are not improving?
No, it's not side effects. It's more just not feeling well. More just not feeling well, like liver side effects, like nausea. No, nausea is a sort of, nausea, headache, brain fog, itchiness sometimes.
Okay.
Yeah.
All right.
But yeah, so
So iron is heavy metal, same as heavy metal.
yeah, so it's like heavy metal poisoning, my
I
husband
see.
is saying, because iron is heavy metal.
Okay. Okay, but then that's why, you stay within the parameters of what
Right, and you
each
check,
supplement
when you
is
supplement people, you don't give them, just tell them take iron and send
recommended
them
doses.
home forever. I've seen, by the way, I've seen a number of women who come in and tell me that they have iron deficiency anemia and they on iron, and I check the hematocrit and they're like 42. So people are told that they have iron deficiency and they forget to stop taking iron. So yeah.
Okay.
So I think that for all of us, it's important to just remember in the back of our minds when we tell patients something, just tell them that it has a timestamp. So you take iron for 3 months and then we have to recheck, or either way, it's for 3 months therapy, and then we have to reevaluate the situation.
Oh, that's a good point.
Forever. It's not like you have anemia and that's it for life, yeah. So that's,
Great point.
that's a good question. Yes, yeah.
Okay, so I'm going to leave it at that. We have so many more questions, but we only have so much time. So before we move on to the raffle, I just wanted to officially thank you, Dr. Rabin, so much
Thank
for your
you.
time. To your husband, who's in the corner
Yes.
somewhere helping with the questions, we appreciate him as well. Thank you. It's nice to hear your dialogue, so that's wonderful. And yeah, again, thank you so much on behalf of myself and everybody else.